Okay, this group of drugs, talking about injectable anesthetics, are meant to take the patient from sedation to completely anesthetized, unconscious. This group of drugs um, produces unconsciousness in anesthetic doses. Some of these drugs you could use by themselves in low doses to sedate them, but what I want you to know is, in general, when you use this group of drugs, they are used, like, so AJ was there sedated, or you see the dogs in surgery, they're sedated. This is the drugs that we will give IV typically, and they'll become unconscious. You can intubate them, and then they move into that stage 3 plane 1. So this group of drugs kind of brings them into unconsciousness, and the majority of these drugs do not have analgesic effects. So, that's not the purpose. That's why we give them a pre-med with an analgesic, because these drugs don't typically produce analgesia. You can use them with other agents. Sometimes they'll be used by themselves. Sometimes they will be combined. Like when I talk about Ket-Val, that's ketamine and Valium. But the majority of the time, some of these drugs will be used by themselves. The other thing that I'm going to talk about, and you have to understand this concept, is most of the time when we give these injectable anesthetics IV, you give them to effect. And let me explain what to effect means. So, for example, propofol is a very common injectable anesthetic. It looks white. And sometimes, like for a dog like AJ, his dose might calculate 8 mils. I mean, I'm just pulling something out of the top of my head. When I give propofol, normally what I tell you guys to do is you're going to give like half of what you have. So if I have 8 mils in the syringe, I say, we'll give like 4 mils. And then, can you open their mouth? Can you pull out their tongue? Did they lose their swallow reflex? Can you pass your endotracheal tube? If you can do all of that, you don't have to give the other 4 mils. You're going to just give it to the effect you want. Now, the effect that I want is, can I pass an endotracheal tube? Are they muscle relaxed? Are they unconscious? And once I reach that effect, I can stop giving the drug. I mean, some of these surgery patients, when I helped in rotation, were pretty sedate with their pre-med. We gave like a quarter of the dose they calculated. We only gave like, the students are like, should I give half? And I'm looking at how deep this dog is. I'm like, why don't you start, like if they had 8 mils, I'm like, give them 2 or 3 mils and give them in even smaller increments. And so this takes a little bit of practice. It's very patient dependent, depending on their pre-med. If I look at how sedate AJ was, if I was going to be giving him propofol, he would only need probably 2 or 3 mils of his dose. He was fairly deep to get him to unconsciousness. So it's going to kind of depend on how sedate your patient is. But I want you guys to know the majority of induction agents, just because you calculate a dose, you're only giving it to the effect that you need. You don't have to give all 8 mils just because you calculated it. A lot of times I throw away, okay, am I frozen? Sorry, I just saw your message, Sean. I guess usually I get a little pop-up window that says unstable, but okay.
I think maybe it might be just my internet today.
Okay. Well, I've had all kinds, like I said, my husband the last couple nights has been working on the computer, so I wanted to make sure. I apologize, my technology has not been fun. So the drugs that I'm going to talk about propofol. I'm going to talk about a drug called etomidate. The only drug you guys might have a hard time finding information out is alfaxalone, because it's so new. I have to look in the book, and it might be in your plum, but it is fairly new. But there might be some information. There is a website that we're going to look at that talks about the drug. And then I'm going to talk about the barbiturates and ketamine, which isn't on here, but we're going to also, so when I email you, I'm going to give you a list of the drugs that are responsible for it. But let me start with propofol, which is the generic name. It sometimes goes by propofol, but it is, and the way we categorize injectables is sometimes we classify them on how long they react. So this is called an ultra short acting, but it's a non-barbiturate anesthetic. So barbiturates were the group of drugs that used to be the gold standard in this category, but they're not commercially available in the US anymore. We don't use I mean, I'm going to talk about barbiturates because they'll be on the board exam, but you guys won't use barbiturates in practice. But they kind of compared all these drugs based on barbiturates. So it's called an ultra short acting non-barbiturate anesthetic. It is not controlled in Indiana. I think California was trying to get it controlled. It may end up being controlled at some point. So it is a Schedule 4 in some states, but currently in Indiana, you don't have to lock it up. And it is used for induction primarily to produce unconsciousness and muscle relaxation. You can use this as the sole agent. You can drip it in slowly to effect. Do like what's called a CRI, or a constant rate infusion. You can do like little boluses. We have a lecture called Canine Feline Anesthesia next term, and I talk about some of the protocols, but it can be used by itself and, just to induce, or the only drug. Now, for you guys in school, this is the drug that you will give to induce them for dogs, to induce them. And then sometimes we'll use them in cats if the kitty magic isn't enough. So I'll get into that. Primarily used in small animals and small ruminants, like if you had a calf, a goat, a sheep. The problem is it can be fairly expensive, and the amount that you would have to use in a cow, an adult cow, would be a lot of drug. And we don't really use this in horses. And one of the main reasons we don't use this in horses, now you could use it maybe in a foal. So if you had a foal and you needed something short acting, but the amount that you would have to use an adult horse, not to mention the fact it's so short acting, that if a horse starts to wake up with this drug very quickly, it could be very dangerous. So because it's so short acting, when we get into horses, we tend to use protocols that kind of like hang on for like a longer length of time. The other use that you might see if you're in specialty care, and because I worked at VCA where we had a neurologist, you can use propofol to treat status epilepticus. If you have a dog that isn't responding to diazepam for seizures, which is rare but sometimes happens, you can put them on what's called a propofol CRI to keep them asleep. I'll give you, like, unfortunately, my old dog, Ozzy, he had a nasal tumor that was pushing into his brain. He had started having seizures. We discovered the tumor was migrating to the brain, unfortunately. Well, one night, it was like 2:30 in the morning, he started having cluster seizures. He'd have one after the other after the other. And I rushed him into VCA, and the Valium barely controlled it. So, they put him on a propofol CRI to keep him asleep. It was the only thing that kind of kept him out of having these cluster seizures. So again, it's not classified, propofol is not classified, as a, the drug used, what's the name of the group of drugs to treat seizures?
Anticonvulsants?
Thank you. My brain just went, It is not classified as an anticonvulsant, but it can be used in seizure patients that are difficult to get out of seizures. I knew that night, not to go off on too much of a tangent, but I knew if we couldn't get him off of the propofol CRI, I was probably going to euthanize him. He was able to come out of it, and he, I mean, I euthanized him within a month, but that night, at least it got him out of the seizures, helped keep his brain calm. And so sometimes it's used in that respect. But from what I want you guys to know, this drug is given IV, and it's given to induce anesthesia, allow intubation. And one thing to know, it's minimally water soluble. The base, this drug is white. So it looks like milk. It's actually an egg lecithin soybean oil solution. So it's a little bit oily. It's white. Actually, they say in people, because they use propofol a lot in people, if you have an allergy to eggs, you have to let them know, because you can react to this egg, this egg base in the drug. It comes as a 10 mg per mil solution, which is pretty universal. And even though it's milky, it's okay to give IV. Now, hopefully it's burned into your brain. It was burned into my brain when I was in school. You do not give anything IV if it is not clear. Like if you're going in the vein and you look at your drug, it should be clear. And then, now this is how old I am. When they came out with propofol, they brought it to Purdue, and we had a teaching lab to try it out, because they're like, here's this new drug. And a bunch of us surgery techs, we went with our anesthesiologist, and like he hands me this drug, and he's like, okay, give it IV. And I'm looking at it and I'm like, I can't. I'm like, it's white. He's like, give it IV. I'm like, I can't. He's like, Christine, it's okay. It's supposed to be white. Give it IV. I mean, I was just so like looking at it going, I'm not supposed to do this. So in general, keep that as a thing in your mind, is that because sometimes people give drugs wrong ways. Most, I would say like 99.9% of the drugs you use are clear if you're going intravenously, except propofol. It works on the GABA receptors. And if you remember the GABA receptors in the nervous system, which kind of initiate that parasympathetic effect, they're not quite sure, but that's where it has its effect, at those receptors, and it's going to bring them to an unconscious state. And because of the oil base and that it's not water soluble, it is highly fat soluble. So it likes fatty tissue, which I'm going to talk about. Some of this drug, whenever you go IV, you're right in the bloodstream. And our goal is to get this drug from the bloodstream to the brain to anesthetize them. The fat is going to take some of that drug. Now, that is accounted for in our dose. If I have an animal that's really skinny, that's lacking body fat, sometimes I reduce my dose, because I know some of this drug does get absorbed by the fat. So I will say sometimes I lower the dose and I'll talk about what we do in overweight dogs, but it's very quick. Once you give this drug adequately, they will fall asleep in about 30 to 60 seconds, but will only last, one IV injection, one bolus, will only give you about 10 minutes of anesthesia. So how I want you guys to know how you give this drug: you give it IV, you're going to pass an endotracheal tube, you're going to hook them up to your anesthetic machine, and then they're going to start inhaling their gas. Because what happens, if you watch what I'm doing on the screen, your propofol is wearing off. But you give them propofol, you intubate. When they start inhaling the anesthetic, as the propofol wears off, your anesthetic gas should be kicking in, because your anesthetic gas is what's going to keep them asleep. Now, what I explained to you before is you could keep giving them a little bit of propofol every 5 to 10 minutes, and you can keep them asleep with just propofol. But normally, your propofol is just to get them unconscious, and then you need something to maintain anesthesia, and that's where your gas anesthetics maintain. Because again, this is gone. And if you just give one dose, Most dogs in about 20 minutes will be recovered, and cats can recover in about 30 minutes. Same for like a calf or a foal. They will wake up from one dose. Once you stop giving propofol, it leaves the system very quickly. So it moves pretty good. The other thing that let me talk about. So I've talked about protein levels and how important they are in anesthesia. So when you give propofol, it does bind to protein. Most drugs do. But if I have an animal with a normal protein and I give a normal dose, some of that drug binds to protein. So I want you to think about it this way. If this is the vein and here's the brain, there's going to be some drug that is bound to protein. Protein doesn't fit through the little holes or the fenestrations in the capillaries. When a drug is bound to protein, it tends to remain in the blood vessel with the protein. Now, some drug is what is called free drug. If it's unbound, that means it's free to travel through the fenestrations and penetrate the brain. So if you have an animal that has low protein, what should I do to the dose of my propofol if I want to use it in an animal that doesn't have adequate protein levels?
Wouldn't you give less?
Yes, you want to give less or lower your dose because in theory you have more drug available and it will increase the potency. So again, you can use propofol in a hypoproteinemic animal. I just use a lower dose because you can always give more. Also, let me say this drug is not reversible. So when you give it, you're stuck. But it goes away fairly quickly. And that's the nice thing about propofol. Doses suitable, I don't always like this statement, can cause unconsciousness or death. One statement that I don't like that anesthetic companies use is when they came out with propofol, they were like, this is the safest anesthetic available. It's so safe. Any drug is dangerous when you don't know what you're doing and you don't know. I mean, this drug killed Michael Jackson. Propofol was the Michael Jackson drug, if you don't remember who Michael Jackson was. Michael Jackson's doctor was giving him propofol so he could take a nap. It induces a state of unconsciousness. Human doctors are abusing this drug because if they want to sleep on their shift, they'll set up an IV, give themselves propofol, fall asleep, and helps induce a state of sleep. The problem is, and I'm going to get into the side effect, is it can cause apnea and you can stop breathing. And that's how Michael Jackson died. He probably went, now maybe he had other drugs in his system, I don't know. But propofol was what he was given, and it was reported that he was having trouble sleeping. Doctor gave it to him, probably got too much, and stopped breathing. So I don't want you guys to be afraid of it, but there are some side effects to be aware of when we give it, and I'm going to talk about how do you deal with the apnea of propofol. Because it's highly lipid soluble, the brain is a very fatty tissue. The brain has a lot of fat. So therefore, if something is fat loving, lipophilic, the brain sucks it up like a sponge. So that's why when we give it, they go to sleep so quickly. It has a high affinity for fatty tissue. And so it gets soaked up in the brain, produces unconsciousness, they go to sleep. And then when you stop giving it, and this is an effect, especially this is important for like a board exam. How are drugs redistributed? If you guys remember from physiology, and maybe you talked about this in chemistry, things like to go from high to low, okay? The body always wants to keep things equal. So the problem is when you give this drug, the brain sucks it up and sucks it up out of the blood. The high concentrations in the brain, the low concentrations in the blood, because the brain just took the majority of it. Not all of it, but the majority of it. When you stop giving propofol, now the brain has a lot of it and the blood doesn't. So what happens is the body goes, wait, we're not balanced. And what happens is that drug will then redistribute. It goes from the brain back to the blood. When it leaves the brain, that's when they start to get light or wake up. And that's why this effect is so quick, because it gets rapidly sucked up to the brain. When you stop giving it, it redistributes from, goes from a high concentration to a low concentration, goes back to the blood, and then it gets cleared from the system. So it's a very rapid induction, rapid recovery drug, it gives us flexibility. One thing that I love about this drug is that doses are not cumulative. So what I mean is, when I give a dose to a dog, in about 10 minutes, that drug is already leaving the tissues. If I give another dose, I don't have to worry about the first dose still being around, if it's about like 5-10 minutes. So I could literally give a dog a little bit of this drug every 10 minutes, and you see what I mean? They're not adding to the other drug. Now, I'm going to talk about drugs like ketamine and diazepam and pentothal. All of those drugs accumulate in the tissues. If you keep giving a dog or a cat ketamine doses, the tissues absorb some of that and it accumulates. And the problem is then you can reach like overdose levels. The nice thing with this drug, it's suitable for redosing. Like you can give, sometimes I've done procedures just on propofol, and I've given dogs 5 or 6 doses of propofol, and they still wake up in 10 or 15 minutes from when I stop giving it. And you'd think, well, gosh, you gave that dog 5-6 doses of propofol. But the first dose is gone. The second dose is kind of like the next first dose, if that makes sense. So another way to compare injectable anesthetics are they cumulative? Propofol is not cumulative. First dose is gone. Second dose then is gone. They're not adding to each other. And the nice thing about propofol, minimal hepatic and renal metabolism. This drug just kind of gets excreted. It doesn't rely on, there's not a good way to put this, it doesn't really tax the liver and the kidney. So you can have a dog with elevated liver enzymes and kidney enzymes, and this drug is safe. I still would probably lower my dose a little bit, but it requires little hepatic or renal metabolism to clear this drug. So again, liver dog, probably not going to have a problem with this drug. And I go, there's lots of, there's a note in this gray box that you probably want to read, but the thing that I was talking about is the partition coefficient, which is like the parts. When a bunch of drug is in the brain and low levels in the blood, that's how a drug redistributes, because it wants to go from high to low. So that's, the drug will then leave the brain. Now, if I give more drug and it goes in the blood, now the brain is lacking, the brain sucks it up. So the drug moves from high concentrations to low concentrations, and that's how it redistributes. And redistribution is that partition coefficient. So when you see that in reading, it's just telling you, where is the drug going? It goes from the blood to the brain. Hopefully that makes sense.
Ms. Lenders?
Yes.
Sorry, I have a question. Back to what you were talking about, like giving more of the drug, the brain will suck it up and not go into the bloodstream, and if it's like vice versa. So is that why we don't give multiple doses of like ACE or atropine whenever they're like having heart issues during anesthesia?
Yes. So a lot of times the other drugs that you give, like, if you give a dose of atropine, some of that drug, the way it moves and the way it redistributes, it stays in the tissues longer, or it has a longer duration of effect. So like, if you guys, for example, if you would have had to give AJ atropine today, that atropine should last 30 minutes or more. Now, like when you give it IV, it doesn't last as long, but one dose, or like ace-promazine will last longer because of the way it moves through the tissues. And so normally, like when you guys look up these drugs, I try to give you guys an idea of length of effect. You know, propofol is something that will be gone in 10 minutes. Like, I'll give you a little preview. Sometimes on a test, I'm like, this dog is 30, 40 minutes into the procedure and he's having these problems. And someone will say, oh, it's the propofol. But if you see on a test, you're 30 to 40 minutes into a procedure, the propofol is gone. So it's not a problem with propofol. There's another reason for the problem, because that drug is so rapidly, so there will be some drugs, and that's spot on. It's those drugs you don't redose as often because they do last longer, and you do have to worry about accumulation, like ace-promazine. I wouldn't redose ACE multiple times. Maybe once you can give a boost dose, or sometimes we call it top off. Generally, it's not as often as propofol. Does that answer your question?
Yes, thank
Okay.
you.
Now this picture, which I don't always, this picture is kind of showing you how it moves through the tissue. So when you give an IV injection, this is just kind of showing you where it moves to. So this group here in the bottom right, which says the vessel-rich group, you can see there's a bigger flow. The brain, heart, kidneys, spleen, muscle is going to, take some, the fat is going to take some. So this is just showing you, whenever you give a drug in the bloodstream, the blood goes to the entire body. Blood goes to your vessel-rich organs, your fat, your muscle. And so this is kind of showing you, but you can see that the majority of the blood flow is going to affect these organs. And of course, because of its fat solubility, that's how you get the rapid uptake into the brain. And this kind of a chart shows, so here's the dose and here's time, which they didn't put the rest of the numbers on the graph. But basically what I want you to know is when you give a dose, it goes from the blood to the brain and also to the fat, rapid distribution. And then when you stop giving it after about a minute, it's already going to start to leave the brain once that drug is redistributed. And that's why they wake up so quickly. Even though the muscle and the fat do absorb some of this drug, it's such a rapid redistribution that they're going to wake up. They don't get a big hangover from propofol. Okay. My radiation patients, when they would come in for radiation, I used to tell the owners, I'm like, come back in about an hour. And they were always surprised that their dog would walk out the door like it walked in the door. Because we didn't give any pre-meds and things. I just gave propofol and put them on ISO. And I just need them asleep so they don't move for the beam. And once I stopped giving, I gave one dose of propofol and I wake them up from ISO. In an hour, they're out the door. So, there's ways to do rapid protocols, and this would be one of the drugs that would do that. Some of the common effects, so the CNS, it's dose-dependent sedation to general anesthesia. What I want you guys to know is the main reason you use this drug is to induce general anesthesia. If you gave a low dose, you could make them just sedate, except that you'll get some like tremors and you can get some shaking. And remember the excitement phase I told you guys about? Normally you go from stage 1 to stage 3. Propofol is the drug that does that. If you don't give enough or you give it too slow, you're going to see stage 2, which is excitement phase. And that's where you can get the tremoring and the howling. So it's not a good sedative drug. It's really meant to keep them asleep or to anesthetize them. And that's where there's no analgesic effects, and you can get some transient excitement and muscle tremors. Now, something that I'll explain, sometimes people think, oh, you can even get paddling and muscle twitching. Sometimes people think this is a seizure. Technically, this drug should stop a seizure. So I'm not saying an animal can't have a seizure on induction. That's rare, and it's rare when you use this drug. But sometimes people, if they don't give enough or they give it too slow, you'll see this paddling and twitching, and sometimes people interpret it as a seizure. Now, I always get my doctor, if something like that's happening, you just have to say, hey, Dr. Paul, Dr. Ritz, or what's this twitching? A lot of times we can just push a little more drug and kind of push them through the excitement. The first time you guys give it at school, you're going to have somebody with you. I mean, I watch the students when they're giving it, and I'm like, slow down or give it faster or stop giving it. I mean, you're going to have guidance to kind of give you like, well, how fast. You don't want to bolus it in really fast, but you also don't want to give it too slow, because then you see more of these CNS signs, the paddling, the twitching, the tremors. It is a cardiovascular depressant, but you do get some hypotension. So it does cause a vasodilation when you give it, and it's a fairly potent vasodilator. Now, when you vasodilate them, you can drop blood pressure. Heart rate sometimes will initially speed up. So sometimes during anesthesia, I'll see the first heart rate is high, and then the heart rate starts to come down. Sometimes that initial boost in heart rate, sometimes it's excitement. Sometimes it's a response to this little drop in blood pressure. But it should wear off. It should wear off in about 5 to 10 minutes. The respiratory effects are key. It is a respiratory depressant, and it is very common to see apnea. Now, what's apnea? If my patient's apneic.
Isn't it like not breathing?
Not breathing.
Trouble breathing?
Yep. So usually lack of breathing. So sometimes in this drug, especially the higher the dose and the faster you give it, you're going to see more apnea. Now, you should give it slowly to effect. You don't want to give too much. So you just give it till you reach your effect. And if you give it slowly and watch your patient's breathing, you might be okay. Now, if they stop breathing, I don't freak out. This is how, if an animal is not breathing, there's two possible things going on. Number one, it's apneic from propofol, or it's going into respiratory/cardiac arrest. How do I know the difference? I'm going to look at their color. I'm going to check their eye position. I'm going to feel their jaw tone. I'm going to check a pulse. You need your other parameters. Now, if I gave propofol and a dog was going into cardiac arrest or respiratory arrest, they might be blue. They may have a very, 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 very slow heart rate, super low jaw tone, central eye position. Do you see there's other parameters that would make me concerned that, oh, this is not good. But in a dog that's apneic from propofol, just not breathing because of the drug, their heart rate is usually adequate. They typically have decent color, even though momentarily they're not breathing. So I have a decent pulse, a decent, pulse rate. I can hear a heart rate. They may have a little bit of jaw tone. They may still have even a little bit of blink. The eyes are maybe ventral medial. They may have a little bit of a pedal. Do you see how I'm using my other parameters to help determine the reason for the apnea? Now, the one thing you're going to do for general anesthesia is you're going to be putting an endotracheal tube in and hooking up to an anesthetic machine with oxygen. You can bag them and breathe for them. The apnea is transient. The apnea is going to last maybe 3 to 5 minutes. The longest I've seen it is like 7 to 10 minutes. But most of the time, I call it a transient apnea. And it's just maybe the dog had a more profound effect. Maybe you gave it too fast. Maybe you gave a little too much. But again, as long as your other parameters are within normal limits, you can just breathe for them and give them oxygen, and the apnea should go away. Anytime you guys get a freaky number, you know, AJ's heart rate today, I think he got down into the 40s. But decent color, decent pulse quality. His jaw was loose, but he had some jaw tone, and he had a little bit of a blink. So the bradycardia that he had today, nothing else was going in a bad direction, okay? And that's why, you know, like I told you guys, you can't really look at one value and freak out. You can look at one value and be concerned, and then look at the other corresponding values. Does anything corroborate? You know, like I said, if an animal is going to be in trouble, there's probably other things that are going to be happening. So hopefully that makes sense. I want to talk a little more about the adverse effects, so I want to stop there. Therefore, you know, I want to, because I like to talk a good amount about propofol just because a lot of clinics use it. It's very, very common, and you guys will use it in surgery rotation. So, okay.